Welcome, everybody. It's my great pleasure and honor to introduce one of the brightest young minds in urology. There are a lot of voices in urology, but this is one of the brightest and I think most insightful and best. Sigrid Carlson joins us from Memorial Sloan Kettering. She started her career in Gothenburg, received her BA from the gymnasium there. And actually, when you received your BA, I'd already been chair 4 years. That certainly dates me. But went on to get a degree in medicine, a PhD in urology, and then went to Harvard for an MPH, very well trained, and then joined Sloan Kettering in 2014 as for postdoctoral fellow. And her career has only really risen since then. I won't go through all the awards and honors; they're considerable. But I think one of her greatest contributions is in this approach to risk-based screening, and you'll hear more about that. And I had the opportunity to hear Sigrid just last year give an excellent introduction on this. She's been very well published in many great top-notch journals, as I mentioned, many awards, and it's certainly an honor for me that I do have a publication with Sigrid, a couple of them, I think, which I rate very, very highly. And I'm going to talk, I'll bring up in the discussion one of our recent editorials. But Sigrid, welcome to UCSF. We're sorry you can't join us, but we'll be sure we get you back here.
Thank you. Thank you, Dr. Carroll, for that kind introduction. I'm sorry I can't be with you in 3D, but I'm very happy to see you on the screen. So with that note, let me share my screen. That's usually the hardest part of a talk. Let's see. Okay, if I do this, how about this? Do you see the full screen? Great.
Okay.
And feel free to type questions in the chat. I don't know if you can unmute yourself in the webinar, but anytime, ask me questions and feel free to interrupt. So I'm very excited to talk to you today about advancing personalized and risk stratified early detection of prostate cancer. So I've been in this field for 20 years, and it fascinates me that it's still so controversial and there's still so much happening. So it's a very exciting field to be in because it's constantly evolving. And when I started, we just had what you see on the screen, the PSA test. And so from there, we have gone really far, and I'm excited to talk to you about that today. This is my funding and my disclosures, none of which are relevant to this talk. So as Dr. Carroll mentioned, I'm a transplant from Sweden to the US. I have a clinical background from Gothenburg, where I did my MD PhD, and I started in residency. I was going to become a urologist, like many of you on the call. And then I moved to New York in the US to do a postdoc, and it was supposed to be 1 year, but here we are 14 years later. And it's interesting how your destiny just unfolds. And it was really the MPH I did at Harvard that really made me really enamored by epidemiology. And so I decided to switch to full-time epidemiology, and that's what I've been doing since. And I am now the director of clinical research at our Josie Robertson Surgery Center, which is our ambulatory surgery center. So most of our prostatectomies we do in this building. So I help with the vision and strategy, and I build teams, and we do a lot of research, and we have several clinical trials ongoing. But most of what I have done also is working on guidelines. So I've worked as a methodologist on AUA and NCCN and other guidelines, and most recently the PCF guideline. And for those of you who know me already, you might have seen me from the Göteborg 1 and 2 trials, which is where I have my background. I worked with Professor Hugosson, who was the PI of the Göteborg trials. And that's where I started my research journey, because I was really interested in, does PSA screening reduce prostate cancer mortality? Because at the time, we didn't know if the answer was yes or no. And the Göteborg trial was one of the key trials there. And part of that became part of the ERSPC, the European randomized study of screening for prostate cancer with 8 European countries, of which Sweden was part of it as well. And now recently, I am a member of organized prostate testing in southern Sweden, in Lund University. And so those are pilot testing programs of organized PSA screening and MRI in Sweden. And that's also part of the EU initiative that's called PraisU that we'll come back to. And it's a new initiative that has just started a year ago. And I also work with the CISNET and the NIH with some modeling studies here in the US. So with that background, let's talk about prostate cancer and PSA screening and why this is so important. Well, as you know, there will be really a tsunami of cases of prostate cancer with changing age structures and improving life expectancy. And this is across the globe. So if you read this Lancet Commission, you've all seen that prostate cancer cases will double and prostate cancer deaths will rise by 85% over the next 20 years. So I really applaud all of you for working in this field because urology is going to be even more important in the coming years. So does screening reduce prostate cancer mortality? That was the question, and the answer is yes, it does. So the Göteborg 1 trial, we showed that regular PSA testing every 2 years of men 50 to 70 reduces prostate cancer mortality by about 30%. And so really screening works. And this we've also shown in the ERSPC, and you are surely all familiar with the PLCO trial in the US that did not show a difference in prostate cancer mortality between the two arms. And does anybody know why that was? Can't really see if anybody's typing in the chat, but the answer is that many men in the US have already had a PSA test. So there was a lot of opportunistic testing in the control arm. So that really diluted the statistical power of the study to find a difference between the groups. So that explained why there was no difference. But if you take this into account, and if you do modeling studies that Alex Sorikov and the team did, you can see that both the European and the US trials showed that screening reduces prostate cancer mortality by 30% after about 11 years of follow-up. So I think we can say that uniformly that PSA screening does work. And if you look at the number needed to screen and the number needed to diagnose to prevent one man from dying from the disease, those numbers become even more favorable with longer follow-up. So you can see, with long-term follow-up, how these numbers have become smaller and smaller. And what's also intriguing to me is the UK CAP trial that was just a single PSA test. Unlike ERSPC or Göteborg, where we screened every 2 to 4 years, this was just a one-time PSA. But also that trial showed that screening can reduce prostate cancer mortality, but not as much as in the other trials, but still there was an effect after 15 years. So that is kind of the paradigm that we started with, but we still have challenges. People continue to die of prostate cancer despite screening. We have a lot of one-size-fits-all or wild testing, and that's associated with a lot of costs. We also see inequity, and there's a lot of harm. And what we have seen is a definitive and sustained increase in metastases in the US, consistent with decreases in PSA testing. And as you all know, the USPSTF recommended against PSA in 2011-12, and then changed the recommendations. And now recently it is a C recommendation with shared decision making. But we can still see the effects of the recommendations against PSA. And most importantly is for mortality. We had seen a downward trend, but that kind of leveled off in the wake of recommendations against PSA screening. And that decline was in all racial groups, but remained highest for Black men in the US. So given this disparity, this is why in the PCF guideline, we recommended discussing PSA testing between 40 and 45 for Black men and strongly considering annual screening for Black men because of increased risks. So we don't want to throw away the baby with the bathwater. We don't want to stop PSA testing altogether, but we can do it much better. So here's where we go into risk stratification. We used to only have the DRE before the PSA test, and this is something that we discussed in the guidelines every year. Should we do both? We say yes, if the PSA is elevated, DRE is definitely part of the diagnostic workup. But as a screening test, it has a very low diagnostic value. So in the German PRO-based trial, the cancer detection rate is extremely low by just doing a DRE. So we don't, say you don't have to do it, but you can do it if you want to, or if the patient wants, but it's optional in most of the guidelines today, but definitely part of a workup when the PSA is elevated. And opportunistic testing is common. 30% of US men of screening age have a PSA test every year. So this is something that men want. And PSA is, even though it has poor specificity, is actually an exceptionally strong prognostic marker of future risk of lethal prostate cancer. And this is something that we have shown from the trials or the cohort studies in Sweden, and specifically in Malmö, where we had archived bloods from the pre-PSA era and followed those men from 60 to 85. And you see that if you're 60 and your PSA is less than 1, then the risk of developing metastases or dying from prostate cancer by age 85 is 0.2%. So that's a very, very low risk. So those men can be excluded from further screening. So that's, a very efficient mean of looking at screening from a negative predictive value, if you will. So now we are in this really interesting phase where we now have an opportunity for a paradigm shift. And I think we're standing right at the shore and looking into the future of what's happening now, where we have risk prediction models, we have novel biomarkers beyond PSA. We also have advanced imaging with MRI and PSMA and other imaging modalities, and also the evolution of AI to interpret the images. So in Europe, this is really something that's moving fast. There's now a climate for targeted screening, and we see that for prostate, we have, for example, the Transform trial in the UK, a large initiative with PSA, polygenic risk score, and MRI, and we have the PRAISE-U consortium, and there's also similar initiatives in breast and lung, for example. So the entire field in cancer early detection is moving towards risk stratified screening. And PRAISE-U is a really interesting initiative funded by the EU. A lot of money invested into this initiative. So we have moved from the trials into implementation. So this is really piloting screening and seeing what's happening in these countries. And so 7 countries are already participating, and Sweden is one of them, and 13 are set to follow in the next few years. And this consortium has been ongoing for 1 year now with the pilot studies to see, the implementation of screening, what's the resources, what are the outcomes, and so on and so forth. So really an initiative to start implementing screening in Europe. And as I mentioned, we used to have only one simple blood marker, but there's been an explosion of markers on the market, both in blood and urine, and also in tissue. So there's a lot of adjunctive tools available for us to better stratify risk. And of course, risk calculators are freely available. We have, for example, the Prostate Biopsy Collaborative Group or the ERSBC risk calculators, and they can be used to help determine who needs a prostate biopsy. So the old paradigm is out, where we just do PSA, jump to biopsy, but we usually do something in between. We also, of course, have risk factors with race and family history, genetic predisposition, and different types of polygenic risk scores are available also. But I would say really the game changer has been the MRI, and I think it's become standard of care. And I'm sure in your practice, many men come to you with an MRI before their prostate biopsy. And you can see here on the screen, this is probably a tumor that's so big that you could see it or feel it anyway, but you get the point that, of course, it's easier to target what you see on the MRI than just doing the random systematic biopsy that we used to. So really, this is how we balance the benefits and harms of early detection. We don't have to do a lot of unnecessary biopsies anymore. So we keep the detection of significant disease, we reduce overdiagnosis by not putting needles into Gleason 6 areas, and we reduce unnecessary biopsies. So really all the ongoing and completed screening trials in 2025 are all based on risk stratification, and most include MRI, I would say. There's a lot of initiatives around the world, mainly in Europe, but also in the US and elsewhere. And you can see that most combine the PSA and some form of MRI, whether it's a biparametric fast MRI or multiparametric, with or without a biomarker in between. And the Göteborg 2 trial, which is then the successor of Göteborg 1, uses this concept of doing first a PSA test and then an MRI and targeting biopsies to the lesions that look suspicious on MRI. And doing so, you can see that you can halve the incidence of insignificant disease while still keeping or increasing the detection of a significant disease, or at least it's not worse than the reference group. And this is another study that just came out from the Göteborg 2 trial, looking at what happens after 4 years, because most of the MRI studies that have been done are kind of cross-sectional. So here you can see that, after 4 years, if you omit the biopsies in men with negative MRIs, you eliminate overdiagnosis, and the risk that those other incurable cancers would progress in the interim is very, very small. So that's a really interesting piece in the puzzle, I think, that it's kind of safe to continue to screen those men that have had a negative MRI. So I would say that this is really the paradigm that we are moving into, that we no longer just have the DRE or PSA, but we have a kind of a funnel approach where you start with assessing the risk in your population by a simple blood draw, and then send those for a reflex test, whether that's another biomarker or a risk calculator or something in between. And then of those, you then go on to the MRI. And then of those, you then send those only to biopsy who show something on MRI. So in this way, you can really reduce a lot of harms that we used to have with just PSA screening and then sextant biopsy, for example. And one such approach has been to combine the 4K score with the PSA, and that's been shown in the Göteborg 2 trial and also in the Finnish ProScreen trial that we have worked with. And so 4K score is a marker that combines clinical information with 4 of the kallikreins, and then gives a risk score. So if you use that in between the PSA and MRI, you can reduce the demand for MRI, and then you can reduce the number of biopsies. And it's really interesting that the negative predictive value was almost 100% from using a cutoff of 7.5%. And similarly, the Stockholm 3 test is another multiplex test developed in Stockholm, Sweden, and that also combines clinical factors and biomarkers and also genetics with including the SNPs. And the same there, you can see how you can reduce the number of unnecessary biopsies, reduce overdiagnosis, but also keep the detection of significant disease. So that is a really, really interesting concept and something that I think is becoming more and more standard of care. But I always like to say that a chain is only as strong as its weakest link. So for this concept of pre-biopsy MRI to really work, we need the whole chain to work. So we need access to high quality MRIs, good scanners, we need standardized protocols and optimized readings of the team and the logistics, and also high quality, MRI targeted biopsy and good biopsy protocols. If you would ask me to do a biopsy, I would probably miss the target, but if any one of you would do, you would, hit the bullseye. So the whole chain needs to work for this to work. And we know that there's a lot of heterogeneity. When you look at these studies, the negative predictive value is far from 100%. It varies a lot. So it's important to know your radiologist and know your team and work with them. Because we have a high proportion of indeterminate MRIs or, PIRADS 3 where we don't know. So especially in younger men, it can be difficult to interpret MRIs. So that's where the reflex test can help before that, so we reduce that number. And we also know how important it is with the reader experience, and that central review is important because we don't want to do scans unnecessary. It's expensive, it's very resource intensive, and we don't want to have unproductive biopsies. And this is just a study showing how the accuracy depends on the reader's experience. And here's 2 radiologists with more than 10,000 readings, and you can see that they have a higher AUC than the local radiologists. So that's why it's important to have expert readers or quality control measures with double readings, for examples. And then what I think is really important, and I think it's coming more and more, Dr. Carol and I discussed this just before we jumped on, both for imaging and also pathology, is to use AI because again, we don't have radiologists and we don't have pathologists, and if we want to have equitable care that is accessible to everybody, I think AI holds really great promise to improve the accuracy and improve access, reduce the disparities, and also to be more efficient and save resources. So this is a study from Professor Huisman's team at Radboud in the Netherlands, where they showed that the AI system had a higher area under the curve than the local radiologist, and that's in terms of lesion location on prostate MRI. So I think this is a really important metrics to be used in clinical practice in combination with the radiologist, where, for example, you can start with the radiologist reading the images and then have the AI kind of double confirm, or you can use them in sequence. And this is also being done for mammography, for example, in some areas in Sweden where we have screening programs. There are already, the AI model helps with the readings there because there are no radiologists. And so if you now think about this whole funnel, isn't it expensive? Well, it could be initially, but if you look at the money or the euros or dollars per quality adjusted life years gained, these types of risk-based screening are actually more cost-effective than just, age-based screening or simple PSA screening that we've had before because you save downstream consequences. And you can never end a talk about screening without mentioning active surveillance, because the major risk of screening is that we find low-grade disease. And so then we have to remember that active surveillance is always connected with the diagnosis of low-risk localized disease. It's now the preferred care option. And I'm always pleased to see Matt Cooperberg's AQUA registry, and year after year, we see how the rates of active surveillance for low risk is increasing. So we still have some way to go, but we are definitely making major strides there. And Peter Carroll and I, together with Freddie Hamdi, who's the PI of Protect in the UK, we recently wrote this editorial on, what is actually clinically significant prostate cancer, because, I think we have to rethink that also. We've been focused a lot on overdiagnosis, and the Protect trial really shows that, many of these men do really well also with, higher grade disease as well. So we have to be cognizant of avoiding overtreatment in our stride for reducing mortality with screening and early detection. So that's all I had, and I would love to have some discussion. I think it's more interesting than just me talking. Thank you.
Ingrid, I'll start off. Excellent presentation and wonderful slides, very informative. The issue is you showed a paradigm of screen with PSA and reflex testing with 4K, and there's a whole host of other things to rescreen with, and then MRI. And I know when I was leading the NCCN panel, really moving in this direction, there was a lot of discussion of whether you'd go to a marker or right to an MRI. And actually, it was my impression in the UK, there was a lot of, and even if Mark Emberton gave a talk on MRI-based screening, period. And so the issue is there a cut point of PSA where you might say, well, look, I'm just going to go ahead right to an MR. So a PSA at 3.5, I think secondary screening, if you have a PSA 9 confirmed, you go to right to an MR. And so the first question is, did you always go in that direction, or is there any time you'll go right to MR? Here in this country, MR is very expensive. I understand that in Europe it's not. But what about that paradigm? And the second question I have for you is let's say you go down that. What I see sometimes now is a patient will get an MRI, PI-REDS 3 with a very favorable PSA density. So if you ever back off on biopsy with the PI-REDS 3, I mean, do you do secondary testing on those? And if you got secondary testing to begin with, it was marginally elevated, does the result change your reason to do the biopsy?
Yeah, great questions. So to answer the first one, I think, what you're alluding to is also what I've observed is kind of cultural differences between the US and Europe. I think in Europe there's been more, MRI has been more available, and but the US is more biomarkers. It's just depending on the markets. I can see the value of a reflex test before the MRI because the number needed to MRI will be so high. If you just go straight to MRI, and a lot of, as we said, indeterminate MRIs. I know in the UK, it's almost like they forget about the PSA and just go straight to an MRI, but there will be just so many unnecessary MRIs, and we simply don't have the resources. But I think, MRI has a lot of benefits, especially that you see the prostate and you get the PSA density. So to your point, a simple biomarker is just the density, PSA divided by volume. And in the Swedish organized prostate testing programs, PSA density is part of the algorithm. So that man that you described will then come back for rescreening again. I think they use 0.15 as a cutoff there about PSA density. But definitely, that's a marker that shows out strongly in all the papers.
We have another question in the chat. I don't know if you can see the chat or not. I haven't answered it this one, but maybe you want. Can you see the question about what would you do with elevated PSA? You go ahead and answer, and I have another. I also want to answer it. Go ahead.
Oh, suspicious. Yeah. Yeah, I mean, I think this patient category is pretty large, right? So what explains the elevated PSA? Is it, BPH? Because when we screen for cancer, we actually also screen for BPH. So we have to take care of these men, right? And so they come back with repeat biopsies, and they don't want to have biopsies, but you still have to follow them according to some sort of schema. And it's if they've had a biopsy and it's negative, even though the markers and the MRI show something, have you hit the target, and should you do a more extensive biopsy? I don't know what you do, Dr. Carroll.
Well, what I would do is make sure that patient saw Katsuru Shinohara, number one. What we have found is, one of the questions I was going to ask you about targeted biopsy, this controversy about targeted and systematic. We've shown results over the years, and they've changed a bit. The issue on the targeted biopsy is how do you target and how many biopsies you take. We have found, and we still see it, that the targeted biopsy will be negative, but a systematic biopsy in the same area is positive. And so we have found most recently is you're missing it's at the edge of the target. Yeah. So actually, instead of going for people like how Wen or Katsuru may want to comment on this, but we have found that just better sampling of the target, you do better. So when these misses that you have are really at the edge. So hopefully this is a fusion guided biopsy done by an experienced person. But I'm always amazed on how often I see men with a negative biopsy who in fact have a high risk cancer that just wasn't detected by good technique.
Yeah.
Messages.
And I think especially the initial biopsy setting, it's important to do the systematic also. In the repeat biopsy setting, you can consider it. But and the other thing, the Göteborg 2 trial, for example, it's a screening trial where men come back for repeated testing. So they're part of a protocol. But early detection in clinical practice is something else.
A great question, I think, from Carissa about transperineal versus transrectal biopsies. You want to weigh in on that?
Yes. And there are, as you know, RCTs, Jim Hu just had his one come out, and the Translate, I think it's called in the UK, with Richard Bryant and Alistair Lamb. I think that one is about to publish soon. I think they have different endpoints with infection or clinically significant disease. So far, I think that they're showing fairly similar. I mean, although the field is moving towards transperineal because of the obvious low risk on infections. In some of the screening trials and organized testing programs, Some of the urologists have advocated for keeping the transrectal because of feasibility. It's, easy to have in your office and so on. So I can see why, as in, in a different resource setting, that could be another route. But I think the whole field has moved towards transperineal. I don't know what you do at UCSF.
I think I'll let maybe Hao or Ketsu. I think there's a movement towards more transperineal.
Yeah.
Matt, do you have your hand up there? You're muted.
Sorry for that. Great talk, as always. You didn't talk that much about ages to start and stop and thresholds. It seems like the trend in the guidelines is toward earlier baseline testing. And your papers from Elmo have shown very low median PSAs at when you test somebody at 45 or 50. So where do you see the evolution in terms of primary care adopting low thresholds? And at the other end of the spectrum, when do we actually stop as men get older?
Great question. We can talk about them for half an hour. No, it's like the unanswered questions in this field. So what I can say about the evidence is from the ERSPC and Göteborg, the core age group was 55 to 69. Screening works for that groups. So that's why USPSTF has gone with that age bracket. So, a lot of primary cares followed that guideline. So, it's okay to start with 55. But we had a paper in the Göteborg trial showing that, the later you start, if you want to reap the benefits, you should start sooner than later. You can halve your risk of dying from prostate cancer if you start before, 55. So between 50 and 55, I would say no later than that. Should you start earlier? Baseline at 40 to 45, that's what we recommended for PCF for Black men because of increased risk, or at least having the discussions at that point. Then we have the ProBase trial in Germany, which is Peter Albert's trial that's ongoing right now, randomized trial starting at 45 versus 50. That will answer your question in 10 years. So, and that, will be the question, because your question is actually how many of those would have progressed between 45 and 50, right? Or can you wait until 50? I think my gut feeling is you can wait until 50, but if you are kind of want to assess your baseline, if you're, want to know your risk, by all means, get a baseline between 40, 45 or between 40 and 50 at some point if you want to. But I think, you can also wait because from the ProBase trial, we saw that, or we've seen that some of those men have also been overdiagnosed, and you don't want to have a radical prostatectomy too early, especially not in young men. So my sense is that no later than 55, between 45, 55, somewhere starting, 50 is a good starting age. But I can't say there's a sharp start, but no later than 55. In terms of stopping, we've seen the changing age structures, and we live longer and healthier, and people run marathons and so on. So I think it's an individualized risk assessment and taking into account comorbidities and heart disease and everything. But we, in the screening trial, stopped at 70, but we have seen that some of the cases come later. So I think you can continue until 75 in a screening program.
We have a question about follow-up for active surveillance. So obviously we're a big proponent of surveillance here. We have a large cohort, but how do you advise on surveillance for a patient with low risk disease or a favorable intermediate risk disease?
Yes, so Dr. Bafarade leads our active surveillance program, and he would know exactly the schedule. But we have, regular PSA tests. I think it's about every 6 months, DRE and clinical exam, and then repeated MRIs and biopsy. I think we have been less frequent with the biopsies in recent years. I think you can extend them, and depending on the MRI also, sometimes using other biomarkers as well to determine risk, tissue-based biomarkers. But it's basically based on clinical exam, DRE, PSA, and MRI and biopsy.
Our approach has evolved as well to try and identify who's at risk for progression and who is not, and make surveillance less intense for those at lower risk. So we've gone the same way. It's interesting, this when you went too early or too late, I'm seeing a lot of young men, especially in Silicon Valley here, getting whole body MRIs and finding an abnormal. I just had a patient from Los Angeles, normal PSA, picked up on whole body MR. biopsies positive. So we're seeing all these advanced, there'll be a new wave of cancer detection with the whole body MRI and multi-cancer detection tests. What about patients who we're seeing men who have low risk cancers who have maybe BRCA1 or 2 positive. So these are people carrying germline abnormalities, but have low risk cancer. Do you have any? I know how we look at those, but there's a lot of controversy about men. Is it safe to do surveillance on men who are carrying a BRCA2 mutation, and yet they have low risk disease?
Yeah, no, it's a great question. I think that's been debated at the meeting. I don't know if Lori Klotz would say take them to prostatectomy, but our approach at MSK and Befar Day, my colleague, and Maria Carlo, our genetics expert, they have a DoD grant, and I think they have finished full accrual for just that population with BRCA1 and 2 mutations and active surveillance to help answer that question. And our approach is the same. You don't have to pull the trigger immediately, but continue to follow them, but with increased vigilance. I don't know if you would say the same.
I would. I think our ability to identify cancer early is much better. And even if you look at rates, it still is unclear that not all these patients will upgrade. So we take a more balanced approach. Obviously, we defer to patients, and there are some who really want definitive therapy. Let's see what else we have here. So someone has a question about, so I think we answered your question, Hal. So what about men? I think if this is Max Bauman here. Max, is this your question about a very large prostate? Maybe tell us what an equivocal MRI is, if it's a PIREDS 3. Can you see that, Sigrid? So yeah, okay.
Yeah, this sounds very clinical to me, and using your clinical judgment, because most of what I've done is more kind of screening guidelines on a large population, but here sounds like you have to use your fingertip feeling and a lot of your clinical experience in a case-to-case management. I mean, I can see your concern about the older gentleman and the, of course, risk of infection increases with biopsy, and you don't want to be too aggressive either. But there's still something, you want to do to help them.
I think the issue here is what's equivocal. PIREDS 3. I think a PIREDS 5 is so. I think a PIREDS 3, big prostate, normal PSA density, that risk is low. I'm not about that. And then the 85-year-old, I'm not sure if when I turn 85 someday, I want you testing my PSA. So we are seeing in whole labs, about 15% of these patients will have cancer detected on those, and these are usually small volume low-grade cancers. We are seeing some, not from UCSF, but we're seeing some patients brought to whole lab or to aquablation who have not been pre-screened and finding significant cancer in a specimen. But my sense is for people who have BPH symptoms you're planning an operation on, I would consider those patients should be screened ahead of time because they're symptomatic patients.
Yeah.
Are there any additional questions? I think I'm seeing all of them here. If not, Sigrid, thank you very, very much, and we will get you here to UCSF at some point. But thank you very much. This was excellent, and thank you again.
Thank you for having me. Great to meet you all.
Thank you. Bye-bye.
Bye. Thank you.